Hello and welcome again to another edition of the Osteopathic Lyceum podcast. Going to go through a paper from the International Journal of Osteopathic... that may be accurate. I'm just used to saying International Journal more than I'm used to saying Journal of Osteopathic Medicine. The other deal is I was just looking at newer articles in the International Journal, so I crossed some wires. Please excuse me. This article is from the Journal of Osteopathic Medicine. It was published March 31st, 2023. And the reason I want to talk about this one is because from an educational standpoint, it's actually pretty excellent. It's nothing's going to be perfect, but it's, as far as I can read on my first pass through it, it's excellent. So the article title is Learning Abnormal Physical Examination Science, an Introductory Course. And I will read through the proper text of this instead of the abstract. Again, the thing that the Journal of Osteopathic Medicine is doing quite well is making everything open access, so people can get it. So to start reading, the acquisition of clinical skills is an essential part of the osteopathic medical school curriculum. As part of our integrated comprehensive history and physical examination course, utilization of a simulation environment expands upon students' understanding of abnormal physical examination (PE) findings that we do not typically see in a student population or in a standardized patient. High-fidelity HF simulation provides students with the opportunity to learn abnormal clinical findings through hands-on practice in an environment similar to actual patient care. By exposing our students to normal and abnormal findings in the simulation settings, they are better equipped to identify abnormalities as they encounter them in a clinical setting. So something I want to note really quickly there that's pretty important is the idea of something that you normally wouldn't encounter to have some level of access to it. One of the biggest problems with any form of medical education is that you don't know what's going to walk through the door, how often it's going to walk through the door, when it's going to walk through the door. So you set up aspirational ranges of things that you want people to get check boxes on to say, I have seen this presentation or I have done this thing. And you can't guarantee that it will happen in, say, a residency approach or in any form of student clinic approach. So you can turn to something like simulation to try to generate that. I was at a talk yesterday. Today is April 9th, 2026, as I'm recording this. So it was April 8th, 2026. It was a talk by Dr. Kimberly Lomas. I believe her last name is Lomas. She is the vice president of medical education innovation for the American Medical Association, so for the AMA. And so this was the Sibley Lecture, and there are awards from the Faculty of Health Science. So one of the awards, I do not remember the woman's name. I don't remember her name, but one of the things that they were talking about that she innovated with, she was part-time faculty, and she did what is called HALO, or High Acuity Low Occurrence. High Acuity Low Occurrence simulation events in pediatric emergency care. So the HALO concept can go anywhere. High acuity, low occurrence. Usually when I hear HALO, I think high altitude, low opening with respect to jumping out of planes. Parachuting? There's a better term for it. There's a better term for that. But anyways, skydiving. That's the term I'm looking for, skydiving. High altitude, a low opening, and it's more military, but high acuity, aka, something's really emergent, or the emergency level is high, something's going very, very, very wrong, but it doesn't happen often, the low occurrence portion. So there's simulation there. So this is something that is being innovated, and people are attempting to use simulation in a variety of medical education settings in an attempt to give people the opportunity to have some level of preparedness for things that don't happen often. So just so that I can tie in things that I'm seeing in other places that will reflect what's happening in this paper. So you would call it a generally positive thing. One of the things, at least with respect to osteopathic manual therapy or OMT, hands-on only, the level of acuity is not going to be as high as you would identify in an emergency setting or emergency medical setting. And the level of abnormality is probably, as far as frequency is going to be much lower than something that would show up to a hospital. So just being aware of that, you can set your parameters on that for how much you as an educator or you as somebody who's involved in an education program think that you need to impart this or import this. One of the things that you could consider is constantly telling students that when something seems very, very odd, they should refer to a higher level of care. They don't need to know what it is. They just need to know that it's exceptionally odd and it should be referred to a higher level of care in the hands-on osteopathy setting. Whereas if you're looking at people training to be doctors of osteopathy, it's more important to provide them with this low occurrence sort of simulation, because they're more likely to see emergent situations as actual physicians with unlimited medical licenses and the capacity to practice in all 50 states in America once appropriately going through board processes. Anyways, to read again. So before I read again, I am praising this paper, but I'm noting that in settings other than the DO or Doctor of Osteopathy setting, you may not need the high fidelity simulation as much as you could interpret from the benefits of this paper. Anyways, to read again. Clinical year students and residents often have low confidence in identifying abnormal clinical findings due to lack of exposure to abnormality in training, which results in poor cardiac and respiratory auscultatory skills. And that's well cited. So the nice thing there is that they're pointing to multiple papers that seem to show the same phenomenon. The hope is if I check them that it points in that proper direction. I'm not going to check this right now. Anyways, to read again, exposure to clinical work during clinical rotations and residency training may not be sufficient to acquire adequate competency in basic PE skills. These findings emphasize the need for students to learn abnormal PE findings at the beginning of their medical education. And I have no issues with this. One of the big challenges of any medical education is that the actual practice of medicine or the actual practice of healthcare is highly variable. You can't teach everything. If you can't teach everything, every detail, especially teach every detail and have the expectation that people will remember it and be able to use it, what you will benefit from teaching is fundamental skill sets that people can build upon to rely on in novel situations. So something like a FAR transfer paradigm works pretty good. And one of the things that seems to help FAR transfer paradigm is integrating basic science knowledge and procedural skill. If you want to know more about that, you can look at the work that I've pointed to in the past from Dr. Nicole Woods at U of T, as well as Jeffrey Chung. I'm not sure where Dr. Chung is working right now. I know that he had gone to Chicago to set up a lab, so he's probably at a university in Chicago, unless he's found a new position. I'm not 100% sure, but those are people that you can take a look at with respect to the integration of basic science skills and procedural skills, or basic science knowledge and procedural skills at the same time. And you'll see that why that becomes important or germane or relevant later on in this paper. So it's decent. It's a good approach. To read again, in various studies, teaching of abnormal heart and lung sounds with the use of HF or high fidelity simulation was timed to follow cardiovascular or respiratory system courses. That is essentially the integration of basic science and procedure. So the auscultation or the identifying of the abnormality and the basic science skill being integrated. So that's more or less integration. To read again, this is in line with the concept that learning of clinical skills should build on existing core knowledge of the basic sciences. There you go. It's just said differently here. To read again, which is usually acquired during the second year of medical school. To our knowledge, limited data exists regarding teaching abnormal clinical findings to first-year medical students, MS1s, or MS1S, but we'll call it MS1s. In this report, the investigators presented the introductory course for MS1s to learn and practice the recognition of various abnormal clinical signs, including heart murmurs and rhythms, lung sounds, measurement of blood pressure, and palpation of the femoral pulse. The investigators hypothesized that MS1s can learn basic PE skills regardless of their limited knowledge of the cardiovascular and respiratory systems, and that the instruction-based simulation is a suitable instrument to achieve this goal. When you're providing the actual clinical skill and the basic science knowledge at the same time. Based on previous information that I'm aware of, you would predict that you would get some pretty darn good outcomes. To read the methods here. Curriculum context. The Institutional Review Board of Lake Erie College of Osteopathic Medicine, LECOM, approved the study as exempt Protocol 26-135. The simulation course has been in existence in the medical school curriculum since 2018, and participation was required for all students. There was no compensation or informed consent for this study. At LECOM, the size of each medical school class is approximately 275 students. During the spring semester of the first year, students start learning and practicing PE skills on peers or SPs, standardized patients. In the current version of the course, the first year of the course covers teaching normal and abnormal PE findings, while the second year of the course focuses on clinical reasoning and patient management. A total of 264 first-year LECOM students participated in the course. The simulation course was conducted in the simulation laboratory equipped with 2 HF high-fidelity mannequins by a group of clinical faculty from various specialties, including emergency medicine, urology, radiology, otolaryngology, and family medicine. The entire course consisted of 96 one-hour sessions equally distributed over 12 consecutive weeks during the spring semester. It was identified that the optimal group size was 3 students per group. Larger groups would not allow for equal student engagement, whereas smaller groups would fail to provide adequate peer-to-peer support to the learners. So just to reflect on that mildly, I aim to, in the Osteopathic Lyceum hands-on in-person curriculum, have people work primarily in groups of 3s with a level 1 attempting to do something that is novel that they've likely not done much of before or done in this particular context for this particular reason. I want the level 1 to do something first, to experiment, to possibly fail, and to require some feedback or benefit from some feedback, and a level 2 and a level 3 will be the ones to provide that feedback for similar reasons. The peer feedback makes a big difference, and it means that the feedback loops are more varied because you can have the correct message and the wrong messenger for a particular individual. So if you disperse that through a group, a lot of times it will self-sort and people will get the information they require from peers because the peers have the appropriate information across time from primary instructor. So you can leverage that right now in any osteopathic educational setting. To read again, the introductory course on learning abnormal PE science contained preparatory materials and practical skills sessions. I'm not going to read absolutely all of the methods, and one of the reasons I'm not going to do it is because they're good. Like, they're really good because they're very thorough. I'm going to briefly read through the didactic part. The didactic part of the course consists of 2 PowerPoint presentations placed on the school's portal to explain how to perform PE on the SimMan mannequin. So one of the things that immediately pops up as a possible concern is that they're teaching how to do it on the mannequin and hoping it will transfer into actual patient encounters. The measurement primarily is the performance on SimMan. However, the phenomena is still valuable because they're gathering information. So they gather both performance information because I think they can gather it from SimMan, and they also gather subjective information. So, how confident do you feel? They ask them these things. So they have a subjective, does Mikey like it measure, and they have an objective performance measure. I may not agree with the specific measures, but they are comprehensive. They are showing positive outcomes on both things. Therefore, I would be more motivated as an administrator or as an educator to grab some of this and use it, because I would have reasonable confidence that it would have a positive impact on student population, student outcome. To read again, also the students were oriented about the learning objectives and expected outcomes of the course. Simulated heart and lung sounds were utilized from the ORIS program, which is available on the App Store for iPhone and iPad. Something that I'm well aware of with respect to something like learning sounds, especially abnormal physical sounds, is that Dr. Jeffrey Norman very, very annoyed at some high-fidelity simulators because they have a limited amount of sounds. So the one that he is particularly unpleased by or unimpressed by is Harvey. So Harvey is a very, very expensive simulator, and it probably has been updated partially because of the issues that can be identified. If you considered how well people performed on heart sounds when using Harvey, because Harvey had limited sounds, versus a $10 CD, which had a very large amount of abnormal heart sounds, the $10 CD outperformed Harvey on performance with respect to identification of heart sounds. So this one that's from the App Store might actually be very inexpensive or free and very effective. So that is actually nice to see, right? Anyways, to read the practical skill session portion, to move on a little bit and skip over some stuff. Course developers assess students' basic PE skills, five-item skills checklist, Appendix C, and confidence in performing clinical skills, and their understanding of the pathophysiology of abnormal clinical findings before and after the simulation. 5-point Likert scale, Appendix D. After completion of the training course, the students were asked to complete a satisfaction survey, 5-point Likert scale, and voluntary anonymous feedback. The total time allotted for the practical skill sessions is 60 minutes, included the following: before simulation assessment, 5-item skills checklist, and confidence surveys. That took about 15 minutes, or they allotted 15 minutes. 2, training with an instructor, which is 20 minutes. To continue to read. Under the instructor's supervision, students performed a series of PE physical examinations on the HF high-fidelity mannequin, starting with the normal, uncomplicated clinical scenarios and progressing to more complex conditions with abnormal physical findings. During the encounter, instructors prompted students about their knowledge of the factors that might affect certain physical findings, i.e. measurement of blood pressure. Learners were also asked about the mechanisms of development of the heart and lung sounds and murmurs, as well as how other components of the PE physical exam can help with assessing the patient's stability. Similarly, the students demonstrated their knowledge of cardiac impulse generation and propagation and how different parts of the cardiac electrical activity are reflected on the electrocardiogram, the ECG, and assessed via physical assessment maneuvers such as palpating for pulses. 3, after simulation assessment, 5-item skills checklist, confidence, and satisfaction surveys. Okay. All of that can be summed up in appropriate integration of basic science and clinical skill. That is, it sounds complicated, but it can be reduced down to that statement. Just because it can be reduced down to the statement of integration of basic science and clinical skill or procedural skill doesn't mean you don't need all those other details. If you wanted to run this again or learn from it, you do need all those details. The omnipresent phenomena is the integration of basic science and clinical or procedural skills. That is the abstraction. That's the far transfer thing that educators can use, but the details will be variable, and the details will be variable individual to individual. What one person needs as a prompt will be different than what the other person needs as a prompt. So it's not that there isn't complication here or challenge. It's that the framework seems to do something positive. To read again, as an outcome measure, learners were required to demonstrate their competency in patient assessment and PE by performing a standardized, objective, structured clinical examination, OSCE-type test with the use of the HF mannequin, and standardized case-specific performance checklists. The accurate completion of all 5 checklist items was required to pass the module. Students who failed to demonstrate competency in patient assessment and PE were remediated after the debriefing. Remediation included repeating the training of the given skill under closer supervision with immediate feedback, which is exactly what you should do. This is a well-designed educational intervention and approach, and it sounds like a very well-designed course with respect to fundamental, high-quality teaching approaches or effective teaching approaches. 4, debriefing informative feedback, which is 10 minutes. Before and after simulation test scores and confidence levels were compared utilizing a t-test. A p-value less than 0.01 was considered significant. Before I read anything else, this course is well designed. They had appropriate measures. They had the ability to identify self-reported confidence and satisfaction. Does Mikey like it? And they also had performance measures. Now, the performance measures were on the mannequin, so there may be a challenge with transfer, but that doesn't mean there is a challenge with transfer. It could be investigated. So how well do these people do now when presented something on an actual patient? Hard to do, especially with abnormal physical findings, but maybe possible, right? So hard to do, challenging, time-consuming, money-consuming. So a problem, but the fact that they have both a performance measure that can be trusted and a subjective set of measures that people will have whatever feeling about that they want to have, this deserves praise. Okay, so to read the results, you know what? I'm not going to read the results necessarily. I'm going to look at some of the tables. So there's before simulation, after simulation table with I think it's the mean. On standard deviation. Okay, some of these standard deviations are very large. I'm not going to worry about that. But with respect to skills, so blood pressure, the mean was 73.6 before and 94.2% after. The standard deviation. Standard deviation for blood pressure before was 44.1, which is gigantic, around 73.6, and then the standard deviation after, so it goes from 73.6 to 94.2, but the standard deviation also shrinks, so it becomes 23.2. So both of those actually went in the right direction, so that's a positive sign. Heart murmurs, 53.4% before with a 49.9% standard deviation. So some people were really bad at that, and some people were really good. 76.3 after, so they got better. They weren't great with heart murmurs. 42.5 as far as standard deviation, so that didn't shrink as much as one would want. It went in the right direction, but not as much as one would want. Lung sounds, 53.8% as kind of the average before, with a 49.9 standard deviation. It went up to 91.2% with a 28.3 standard deviation, which is actually a really good improvement. Central pulse, 71.7 before, with 45.1 standard deviation, 89.3 after, with a 30.9 standard deviation. So that standard deviation going down is the thing that tells you the population is actually showing general improvement, because they're getting tighter around the mean. It's still, a decent size. I don't like the size of it, but it's better than 45.1. Heart rhythm, 63.3% before, with a 48.2 standard deviation, which is pretty damn big, and 92.7 after. So that's a really good improvement, and 25.9 as a standard deviation. So again, getting tighter around that mean. So those are very positive things. So you can see on the mannequin, there's really good improvement on most of these, and shown both by increase in average or increase in mean as far as accuracy is concerned, and decrease in standard deviation. So people are getting closer to one another around that mean. That is important. That makes a difference. You look at table 2, confidence levels before and after simulation. Question, I developed a better understanding of the pathophysiology of heart murmurs, rhythms, and lung sounds. 3.4, which is out of 5. Standard deviation is 0.9. So, that's pretty close. I am confident in my skill of taking blood pressure. 4. Oh, wait, no, I got to do before and after. Whatever. What I'll say, because scrolling around this and reading these all out, not the best. But if you were to look at it, you go from 3.4 to 4.5, 4.1 to 4.6, 2.7. What's 2.7? I am confident that I can distinguish systolic and diastolic heart murmurs. The 2.7, so like no confidence or almost none, to 4.2. So that's actually pretty good. The next one's a 2.9. I'm confident I can distinguish various lung sounds. That's 2.9 before, goes to 4.5 after. Yeah, these are good changes in self-efficacy or reported self-confidence. That's important. And it lines up with identifiable improvements on the mannequin in performance outcomes. This is kind of like, did they like it, the satisfaction survey? And yeah, the lowest measure with satisfaction out of 5 is 4.4. So they liked it. It improved objective performance. It improves self-confidence. This is well done. It's well integrated. I want to praise this. The thing to take away from it is a good example of how one can integrate basic science and procedural skill or clinical skill together if you understand the point of it, and you understand that you have to have feedback mechanisms when an error is generated that the student doesn't necessarily know they've created or committed, that the instructor or somebody else is able to identify it and provide that feedback. It's one of the reasons you leverage near-peer feedback and near-peer teaching. So those groups of 3, it's one of the reasons that you have enough instructors that can properly interact with that. So you don't go beyond a certain number of total students without adequate levels of top level supervision so that they can identify error and provide feedback. You understand that people are going to improve as opposed to start off awesome. They should start off okay, especially if they get to the self-sorted level of somebody who's attempting to enter a healthcare profession. If you're talking about medical school, these are smart people. They're well self-sorted. They have likely demonstrated good proxies of the ability to learn and the ability to self-reflect and self-correct. But if you integrate the teaching of the basic science mechanism and the procedural skill, so the how and the why, right? The why being the basic science, and the how being what you're actually going to do, they tend to seem to be better at adjusting when requested. So that's the work that you can see from Dr. Nicole Woods and Dr. Jeffrey Chung, and probably a bunch of others. Those are the ones that I know well that come to my mind. But that integration of the basic science, aka the why, and the actual hands-on skill, the how, you're priming for FAR transfer. The why is the abstract concept that would drive the behavior of the how. So if you know the why, you seem to be better at adjusting because of the why, or adjusting the how because of the why. So if you have to put a patient in a different position to get to the same goal, if you have to change the procedure in multiple ways to get to the same goal, you understand why you are doing it, what the signal was for you to do that, to make that adjustment, because you understand the how, but the how is driven by the why, or the steps are driven by the finding or the abnormal process or the abnormal presentation. So if you understand the abnormal presentation at a basic level, then you seem to be somewhat better at adjusting to the needs of the patient in the moment, and that is high quality teaching supported by the best evidence that I'm aware of in a variety of ways. This is a really good intervention. It's a well done paper because the methods are very clear. So if somebody wanted to import this into their educational setting, they could. What I would want to make sure that you understand is the fundamental thing here is the integration or the teaching at the same time of the how and the why, right? So the why, again, basic science mechanism, and the how, the step-by-step. And you want to make sure that you're being clear about that and explicit about that, because it's like, hey, sometimes you're going to need to change this, or this is going to look a little bit different, but this is why you would do this, and this is how you would do this. And if you can show them more than one way to do the how, then you're priming better for FAR transfer. So you tell them the why, which is the sort of the concept that's always going to be there, and you show them how in multiple ways, or you allow them to develop multiple hows, and then you give them feedback and refinement. They're more likely to perform at an acceptable level in a novel circumstance. Again, the highlight of any healthcare practice is novelty, even if it's tiny day to day. But the novelty is probably more the highlight than the similarity, because the novelty is the driver for adjusting care to the individual, as opposed to delivering care based on previous knowledge alone. So if you another way to say that, in the attempt to be respectful, is the research paper can tell you how somebody else did it. And if you just do it how somebody else did it without paying attention properly to the context and the variation of the patient, then you can screw it up. But you can offload the responsibility to the research paper. So, well, the research paper said this was the best practice. It's like, yeah, but the actual best practice is adjusting to your patient. What I've seen with respect to something like best practice guidelines is that they do leave room for adjusting to patient, but the problem is, as a professional, you can offload responsibility to the best practice guideline, because if the best practice guideline was followed and it didn't work, well, you can say it's the guidelines' fault. So there's a little bit of tension here, and it's tension that I clearly am concerned with because I talk about it, and you've seen me talking about best practice guidelines and some of the challenges that I have with them, as well as when I consume them, some of the challenges. Unfortunately, in the last video, I was laughing about them. I don't think maniacally. I mean, I know I wasn't maniacally, but I was definitely laughing because as far as I can tell right now, as I said in the previous video, best practice guidelines seem to be written by people who think their colleagues are dumb. Whereas this particular paper is trying to tell you how to do things better, being very clear about it, telling you why they were doing it, telling you how they were doing it, so that you could maybe abstract and put this into your own circumstances or your own setting or your own context. So I think this paper is really good as an example. To maybe use it well, I would suggest that you understand the fundamental teaching concept that's here, which is the integration of basic science knowledge with procedural skills or clinical skills. So if you've listened this far, thank you for listening. Hopefully you've learned something, and we will talk again soon.